my name's Leanne and I'm a registered nurse in Whitehorse General Hospital. I am doing a course with BCIT for the NSPN 7150 on the breastfeeding experience. These are my helpers. This is Benson and this is Theodore. And we're going to talk to you today about blocked ducts and a tongue tie. So we're going to talk about the blocked duct. Using the clinical decision-making framework, we're going to talk about the blocked duct in terms of knowledge. Knowledge is the what. What is a blocked duct? A blocked duct is one through which milk can't flow due to a blockage of some kind in the tiny tubes of the alveoli. Jack Newman explains how thick milk can cause the blockage or plug in the duct. An abundant milk supply plus a baby who doesn't latch will result in a partial emptying of the breast. Whatever milk left over sits in the breast and thickens, which blocks the duct. The cause can be anything that prevents good drainage, causing the blocked duct. So this could be a poor position, a shallow latch, a tight bra, breastfeeding to a schedule instead of on demand, infrequent feeding, previous breast surgery or scarring, nipple piercing, or a blocked nipple pore. Let's talk about the cues for a blocked duct. Some signs and symptoms that a blocked duct is occurring can be local pain in the breast in the area of the blockage. There may be an obvious breast lump, a large area in the breast with painful engorgement. However, the mother herself may feel well and have no symptoms at all. Usually a fever is not evident. When we talk about the judgment of a blocked duct, we're going to be looking at ruling out different causes that could be happening. Is this in fact an abscess? Is it mastitis? When we look to the blocked duct in terms of how we're going to continue with our care, we're going to be focusing on our three priorities, which is feeding the baby, emptying the breast, and teaching the mother dyad how to feed effectively. Continuing on with the decisions to make for the blocked duct. The first thing we could think of is prevention. How can we prevent this from happening in the future? And how can we prevent this from happening in new mothers? The most important thing is to have a good latch and great position. Remember to let your baby finish on one side before moving to the next. Use gentle breast massage and compression on any area that feels engorged while you breastfeed or use a breast pump. Change your restrictive clothing so that you have adequate milk supply. In terms of treatment of the blocked duct, we want to make sure that we're feeding our baby often. It's the most important way to relieve a blocked duct. Okay, you feed your baby, Benson. You want to check to make sure that the baby is latching deeply and not just on the tip of the nipple. Use gentle breast massage or breast compression, either while breastfeeding or while using a breast pump. Trying different positions to empty different parts of the breast and have different pressure on different areas of your alveoli. There's unusual positions that you can try, such as kneeling on all fours while the baby is lying flat on the floor. These may feel uncomfortable at first, but it's a way to ensure that you are, in fact, using more than just the three most basic positions. Warm or warm compresses can help relieve the pain. Cold therapy is a good way to help as well, but usually you want cold therapy after you have fed. Warm compresses before you feed. Check whether you have a nipple pore that is blocked. In this case, you may be able to express or lance the pore to create a better milk flow. Taking any Taking anti-inflammatory medication may help as well with pain. A blocked or plugged milk duct usually resolves in 24 to 48 hours. If there is any pain or discomfort that occurs longer than this, we want to think about other diagnoses that may be happening. Blocked duct. In terms of evaluation, we want to see how we're doing as a teaching unit and what we think of our care. Is the baby being fed? Are we moving the milk? And is the mother and baby dyad learning how to breastfeed as a unit? Do we need to inform anybody else or bring anybody else on board? Would a lactation consultant be important at this point? And how does the mother feel about the plan? This is the most important part, especially as healthcare professionals. We don't want to influence them and create our ideas for them. We want them to feel comfortable with the plan that they come up with as well. Now let's talk about tongue tie, our second condition. So when we talk about tongue tie in terms of knowledge, we want to know what it is. Tongue tie, also called ankyloglossia or short frenulum, are the terms used when the lingual frenulum is short and restricts the mobility of the tongue. Tongue tie can also affect the way a child eats, speaks, and swallows, as well as interfere with breastfeeding. The causes of tongue tie is the shortening of the lingual frenulum or the attachment to the bottom of the tongue. The cause is usually unknown, and it's perhaps a genetic component, but they still don't know the exact cause. There is some cases or some research that shows that this case is more common in boys than females. Our cues that a tongue tie is happening in an infant is usually when there is difficulty lifting the tongue to the upper teeth or moving the tongue from side to side, like so. Also, a baby may have trouble sticking its tongue past the lower front teeth, like so. A tongue that appears notched or heart-shaped when stuck out, or a last cause or a last sign that you may notice is a poor latch and or nipple trauma that can occur. In terms of judgment for the tongue tie, we want to know what's happening is actually the cause of a tongue tie. Are there breastfeeding problems that are correlating with it? Maybe speech difficulties later on in life, poor oral hygiene for an older child, or challenges with oral activities. This could be licking an ice cream cone even when a child is 4 or 5 years old, if not diagnosed as an infant. In the decision model with the tongue tie, treatment for tongue tie is very controversial. Do we give the treatment right away, or do we wait and see if it resolves itself? Occasionally, the lingual frenulum loosens over time, resolving the tongue tie restriction. In other cases, it persists, causing problems later in life. Surgical treatment of the tongue tie can be done as an infant, as a child, or adult. The two options are a frenotomy, the removal of the frenulum, or frenuloplasty, where they actually take the frenulum and reshape it to make it more structural sound. In terms of evaluation with the tongue tie, we have to think, what do we need to do? Can we simply assist the mother to have a deeper latch, or is the tongue tie affecting the latch that we need to make different arrangements or have a procedure done to correct it? Do we need to inform anyone, such as the lactation consultant, or can we continue on with our care based on the effectiveness of the latch? Again, the most important things are that we are moving the milk, feeding the baby, and teaching the mother diet into a comfortable plan that they feel safe with. In terms of conclusion, there's many breastfeeding complications that can occur. A blocked duct and a tongue tie are two that can easily be resolved or treated, or a plan made to work within those realms. However, the most important principles that need to occur are that we're moving the milk, that we're feeding the baby, and that mother and baby feel comfortable with the plan to move forward. As long as we feel comfortable in those three principles, we should be able to move ahead and have a happy, healthy, and effective feeding journey for mom and babe. Thank you for listening to my presentation. See you, bye-bye.